So, hello everyone, good evening. Myself, Dr.Tejas.K. I am faculty of pharmacology at Nextillo. So, I welcome you all to this platform. Nextillo, the wonder has a name. Before starting the topic, I would like to thank special thanks to Dr. Sunil sir for providing this platform to us. And you can subscribe to the Nextillo channel, and you can download the app of Nextillo and use the coupon code that is helping hand so as to avail the app for 3 months at just 89 rupees. So with this, we will start the today's topic. So our learning objectives for today's discussion will be pharmacotherapy of diabetes mellitus. So we will discuss this first with insulin and then with oral anti-diabetic drugs. So in insulin, we will see the role of insulin in diabetes mellitus. What are the pharmacological actions and mechanism of action of insulin? What are various insulin preparations? Indications of insulin in type 1 as well as type 2 diabetes mellitus, and adverse effects of insulin. Then we will learn oral anti-diabetic drugs also. So we'll first classify them, and then we will see each group characteristics one by one. And it will be followed by 5 MCQs and then question of the day. So stay tuned. First of all, what is diabetes? As we know that we have already learned in biochemistry lecture. So diabetes mellitus is a metabolic disorder which is characterized by hyperglycemia. So this hyperglycemia, when we will say, so fasting blood sugar, if more than or equal to 126 milligram per deciliter, or postprandial more than or equal to 200 milligram per deciliter. Then what are the other signs? Glycosuria, hyperlipidemia, hypoproteinemia. And what is the reason behind it? There is absolute or relative insulin deficiency. And what are the symptoms of patients? Polyuria, polydipsia, polyphagia, and despite of which there is a progressive weight loss. Right. And how many types of diabetes are there? So there are so many types, but 2 types are considered as major types. That is type 1 diabetes mellitus, also known as insulin dependent diabetes mellitus, and type 2 diabetes mellitus, that is non-insulin dependent diabetes mellitus. In type 1, there is destruction of beta cells of pancreas, and it is an autoimmune process. The age of onset in type 1 is acute, and it is about 15 years. There is absolute deficiency of insulin. So for treatment of this type of diabetes, insulin is must. Insulin is essential. While in case of type 2, which is the more common form, which occurs at middle age, the risk factors for developing type 2 diabetes mellitus are overeating, obesity, underactivity, and aging. It is associated with increase in glucose production, and there is no deficiency of insulin, but there is resistance to insulin. Means insulin level is normal, but the effect is not coming. So how to manage it, we will see. So first of all, we will start with insulin. Who discovered insulin? You can just write down in the comments who discovered insulin. Okay, just 30 seconds. You can write down if you know in comments below. Who discovered insulin? Yes, quick. Discovery of insulin by which scientist? Yes, Vishnu, you can write down. What is your answer? Who discovered insulin? Yes. So you are right. Insulin was discovered by Banting and Best, okay, in 1921. And for that, they got Nobel Prize. But there is one drawback with insulin, that being a proteolyte, being it is destroyed by proteolytic enzymes in gut, we cannot give insulin orally. So that is a major drawback of insulin, that it has to be given parenterally. And what is the route of administration of insulin? That is subcutaneous route. Remember it. The regular route of insulin is subcutaneous. And what are the various sites? So remember, it is abdomen, buttock, anterior thigh, and dorsal of arm. It is given commonly in abdomen, but remember, it should not be injected around the umbilicus. Other than that, we can give in abdomen, buttock, anterior thigh, and dorsal of arm, except around umbilicus. In case of emergency, that is diabetic ketoacidosis, we can give regular insulin by intravenous route. So what is regular insulin? What are other preparations that we will see? But right now, just remember that regular insulin can be injected intravenously in case of medical emergency. Now we'll see what is the role of insulin in diabetes mellitus, or say physiological role of insulin. So before that, insulin is secreted from which cells? Organ, I will say pancreas. Okay. So it is secreted from which cells of pancreas? You can write down your answer in the comments. Yes, go ahead. From which cells of pancreas the insulin is secreted? Yes, Yaduvendra, you have correctly right. Karthik, you are also right. So these are the beta cells of islets of Langerhans of pancreas. Right? We know in physiology. So remember, the beta cells of pancreas secretes insulin. But how this secretion occurs? Of course, in response to glucose. But what is the mechanism? See, whenever a person takes a meal, so what will occur? Glucose will be produced. Now this glucose without insulin cannot be taken up by liver, muscle, and fat cells. But the presence of insulin is must. So what is the mechanism? We will see. This glucose comes to the pancreatic beta cell, and where there is a GLUT2, that is glucose transporter 2. So glucose is taken up by GLUT2 inside the pancreatic beta cell, so that ATP generation will be there, and this will close the potassium channels which are ATP sensitive. So this closing of potassium channels will lead to depolarization. so that the calcium channels are opened. And this will lead to the exocytosis of the vesicles containing insulin. So this is how insulin is secreted, right? So what is the role of insulin? Whenever glucose is produced, mainly after a meal, then increasing level of glucose, pancreas will respond by secreting insulin, and in presence of insulin, liver and other tissue can take up the glucose so that homeostasis is restored and the blood glucose level comes to normal. So this is how insulin maintains normal glucose level. And what are the pharmacological actions of insulin? So remember, basically, the basic action of insulin is to maintain blood glucose level. Whatever insulin does, it controls the blood glucose level. So insulin will do all the processes which insulin will inhibit all the processes which add up the glucose to blood. For example, glycogenolysis, gluconeogenesis. These processes will increase glucose, but insulin will inhibit these processes. And insulin will stimulate all the processes which utilize glucose from blood. The most important being peripheral utilization of glucose. So what is this peripheral utilization? Mainly by liver, skeletal muscle, and fat cells. Insulin will also stimulate lipogenesis and protein synthesis. So lipogenesis will be stimulated, protein synthesis will be stimulated. At the same side, lipolysis will be decreased, proteolysis will be decreased. So ultimately, the role of insulin is to utilize glucose so that blood level of glucose comes down, right? So we have seen the role of insulin, pharmacological actions. Now we will see mechanism of action of insulin, that how insulin presence will make glucose to be taken up by these peripheral tissues. So this is the structure of insulin receptor. Insulin receptor has 2 alpha subunits and 2 beta subunits. And this receptor is transmembrane enzyme linked receptor. The insulin receptor has 2 alpha subunits which are extracellular and 2 beta subunits which are transmembrane. And these are linked together by disulfide bonds. Alpha subunit carry insulin binding sites, while beta subunits have tyrosine protein kinase activity. So binding of insulin to alpha subunit will lead to internalization, and it activates tyrosine kinase activity of beta subunits, so that there is phosphorylation of tyrosine residues of insulin receptor substrate, that is IRS proteins, which is followed by a cascade of phosphorylation and dephosphorylation reactions, so that ultimately second messengers like phosphatidyl inositol triphosphate, that is PIP3, will be generated. These second messengers like PIP3 also mediate the action of insulin on the various metabolic enzymes. So this insulin as well as PIP3 stimulates glucose transport across the cell membrane by respectively GTP or ATP dependent translocation of glucose transporter 4. Remember, this is the most important line in the mechanism of insulin. It causes translocation of glucose transporter 4. So glucose transporter are present in cytoplasm, but with these all actions of insulin and second messengers, this GLUT4 comes to the membrane, right? So that so that with the help of GLUT4, the glucose is taken up by tissues. Over a period of time, insulin also promotes expression of genes directing the synthesis of GLUT4 as well as the regulatory proteins. So this is the long-term effect of insulin. So understood? This is the mechanism of insulin. Now we come to one of the most important question of this topic, that is insulin preparations. So we will divide insulin, we will classify based on the source, purity, and onset of action. First of all, based on source. So based on source of insulin, it may be bovine, it may be porcine, or human insulin. Bovine means it is obtained from ox. Porcine means it is obtained from pig. And human insulin is prepared by recombinant DNA technology. Remember this? Human insulin is prepared by which technology? Recombinant DNA technology. So based on purity, insulin can be conventional. Conventional means based on source, bovine and porcine, these two. So these two collectively are called as animal source insulin. So historically, animal insulin was first used before availability of human and newer insulin preparations. So what was the problem with this animal source insulin? There were loads and loads of allergic reactions happening. So which is not a problem with human or newer insulin, or we will say this problem is very less with human and newer insulin preparations. So the second type of insulin preparation based on purity is again human insulin. So what are the names of human insulin? You should know. That is regular insulin, lente insulin, isofen insulin. And the third type of insulin preparations based on the purity, newer insulin analogs called as Lispro, Aspart, Glulisine, Glargine, etc. So now we will see the third type of preparation of insulin, which is the most important. All of you should remember this, based on onset and duration of action of insulin. So we have divided based on onset and duration, insulin, rapid acting insulin, short acting insulin, intermediate acting insulin, and long acting insulin. Rapid acting, you can remember by LAG, leg. There is no leg in rapid, so you can remember, but there is leg. Lispro, Aspart and Glulisine. Okay, रैपिड में लेग नहीं होना चाहिए पर है, तो लिस्प्रो, एस्पार्ट एंड ग्लूलीसाइन. रिमेंबर, short acting, one and only regular insulin. Intermediate insulin, lente insulin, which is also known as insulin zinc suspension, and NPH insulin, that is neutral protamine hagedon, also known as isofen insulin. In long acting, we have glargine, insulin glargine, and insulin detamir. So remember, only regular insulin can be given intravenously. So whenever we want to give IV injection, we prefer which insulin preparation? Regular insulin. about rapid acting, there is an advantage. So in contrast to other preparations, the advantage of rapid acting insulin is that their duration of action remains constant, that is about 3 to 5 hours, irrespective of dose of rapid acting insulin. So this is an advantage of rapid acting insulin. What is the advantage? The duration of action remains constant, about 3 to 5 hours. If we see the mixing combination of insulin preparations, the rapid acting ones can be combined with regular insulin as well as NPH insulin. Regular insulin can be combined with all of the insulin preparations except the long acting preparations. These long acting preparations will act up to 24 hours. And remember, insulin degludec is an ultra long acting insulin which can act up to 40 hours. So this is ultra long acting insulin which acts up to 40 hours. So this is about insulin preparations. Now we will see the newer insulin delivery devices. So these are like insulin pen. You must have seen the person of diabetes mellitus taking insulin injection by himself or herself with the help of this pen. So these are the portable devices available of insulin. Another is inhaled insulin. In case of earlier, the inhaled insulin had led to the fibrosis and lung cancer. But in mid 2014, new inhalational insulin got FDA approval. But remember, this is again contraindicated in bronchial asthma and chronic obstructive pulmonary disease. Another type is continuous subcutaneous insulin infusion. So these devices are available with insulin pump and rapid acting insulin preparations like Lispro, Aspart. These are preferred for use in CSII, that is continuous subcutaneous insulin infusion. So that may be your MCQ question, that which insulin preparations are preferred in CSII. So remember, rapid acting insulin are preferred. Now we know that insulin is used in treatment of diabetes mellitus, right? But in diabetes mellitus, which type of patients should be treated with insulin? So you can write down your answer in the comments. Insulin is given in diabetes, but in which situations or what type? Type 1, type 2, or even in type 2, which situations? You can write down your answer. Okay, 30 seconds will be given. You can write down your answer. Insulin is given in diabetes mellitus, but in which conditions it should be administered, or which type of diabetes it is given? Just be quick. First of all, see, it is given in type 1 or type 2. It is compulsory in which type? Type 1 or type 2? Yes, very correct. Type 1, all patients of type 1, insulin should be given. Now, in case of type 2, even if it is not controlled with diet and oral drugs, so whenever a new case of diabetes mellitus comes of type 2, it is managed by diet and exercise. Then, if it is not controlled, then we start oral drugs to control the type 2 diabetes mellitus. So these are the oral anti-diabetic drugs. We are coming on that. So if patient is not, the patient's blood glucose level is not controlled, even if diet, exercise, and oral drugs, then we can use insulin, especially non-obese patients of type 2, we can give. Whenever there is a medical emergency, like diabetic ketoacidosis, then we have to give insulin. We cannot give oral drugs in case of emergency. So in case of DKA, the drug of choice is regular insulin. Remember, regular insulin is given intravenously. So regular insulin intravenously is the drug of choice for diabetic ketoacidosis. Then during pregnancy, if a patient is having diabetes, then we have to give insulin during pregnancy. Under stressful situations like surgery, infection, trauma, then we have temporarily, we have to give insulin. Then if this situation is over, then we can again switch over to the oral drugs. So these are the indications of insulin. And what is the goal? The goal is to maintain fasting blood sugar level between 90 to 130 milligram per deciliter, and postprandial blood sugar level less than 150 milligram per deciliter, and glycated hemoglobin should be less than 7%. What is the dosage of insulin? So the dosage of insulin is in international units. So the 1 milligram of international standard of insulin is about 28 units. So remember this, 1 milligram of insulin is about 28 units. So the dosage of insulin is under international units. Now we will see the adverse reactions of insulin. What are the adverse drug reactions of insulin? So first and foremost is hypoglycemia. How a person, a patient of diabetes mellitus will know that he or she has hypoglycemia? So these are the symptoms of sympathetic nervous system, like tachycardia, sweating, anxiety, hunger, fatigue, and weakness. So here there is an important drug-drug interaction. Suppose a patient of diabetes is taking insulin, and patient is also under beta blockers. So these beta blockers can mask the all warning signs of hypoglycemia, because beta blockers are sympatholytic, and all of these symptoms of hypoglycemia, these are because of activity of sympathetic system. So if patient is under beta blocker and takes high dose of insulin, patient will never know that he or she is under hypoglycemia. So this type of patient can go in coma, hypoglycemic coma. So remember, beta blockers can mask all the warning signs of hypoglycemia except one sign, except one, that is sweating. Because why beta blockers cannot mask this sweating sign? Because this sweating is mediated by sympathetic cholinergic fibers, not adrenergic fibers. And beta blockers can only block the adrenergic fibers sympathetic system, not cholinergic. So this is an exception. So this becomes your MCQ question, that which sign of hypoglycemia cannot be masked by beta blockers? So answer is sweating. Another problem of insulin is lipodystrophy. So why it occurs? Because of repeated injection of insulin to the same site. So we can advise to patients that you can change the site of injection of insulin frequently, so as to prevent lipodystrophy. So this lipodystrophy, because of insulin is preventable. Third problem with insulin is insulin allergy. And this allergy was a problem with animal type of insulin. But nowadays, human and newer insulin is available. So this type of problem is less and less. Last problem with insulin is insulin resistance. So this is the decrease in sensitivity to insulin. So this insulin sensitivity decline gradually with increasing age. And remember, obesity is the most important factor causing insulin resistance. So in obese patients, the insulin resistance will come. There are more chances of insulin resistance. So here we complete insulin. And now coming to oral anti-diabetic drugs. So remember, these oral anti-diabetic drugs, these are useful only in type 2 diabetes mellitus. They are not used in type 1 diabetes mellitus. They are not used during emergency, like diabetic coma, which is also known as diabetic ketoacidosis. So it is not used in emergency, not used in type 1 patients. So only these oral drugs are useful in type 2 diabetes mellitus patients. So what is the classification of oral anti-diabetic drugs? So we have divided these oral anti-diabetic drugs into 3 groups. Those drugs which increases insulin secretion, those drugs which decreases insulin resistance, and miscellaneous drugs. So those drugs which act primarily by increasing insulin secretion are sulfonylureas. These are again first generation and second generation. In first generation, we have tolbutamide. In second generation, we have glibenclamide, glipizide, glyclazide, glimepiride, etc. Then the second group in increasing insulin secretion is meglitinides. The examples are repaglinide and nataglinide. And the third group is DPP4 inhibitor, that is dipeptidyl peptidase 4 inhibitor. We'll come to that each group. Just remember right now the names of DPP4 inhibitors. These are sitagliptin, vildagliptin, sexagliptin, elogliptin, linagliptin, etc., etc. So the name of DPP4 inhibitor will end with gliptin. Okay, sitagliptin, vildagliptin, like that. The drugs which decrease insulin resistance are, the first and foremost is biguanide. And the one and only drug which is used amongst biguanide group today, as on today, this is metformin. And remember, metformin is considered as drug of choice in type 2 diabetes mellitus patients. What is the drug of choice? Metformin. Another group is thiazolidinediones, like pioglitazone. In miscellaneous, we have alpha glucosidase inhibitor like acarbose, maglitol, and voglibose. We have dopamine D2 agonists like bromocriptine, and SGLT2 inhibitor, that is sodium glucose transporter 2 inhibitor. The examples are dapagliflozin, canagliflozin, etc. So the name of SGLT2 inhibitor will end with gliflozin, like dapagliflozin and canagliflozin. So this is the classification. Now we will see the characteristics of each group one by one. So first of all, we will see sulfonylureas. Sulfonylureas are one of the oldest group. They were discovered during Second World War. Amongst first generation, all of the drugs are obsolete except one, that is tolbutamide. These are effective orally if at least 30% of beta cells are functioning. Otherwise, this group cannot work without the presence of beta cells. And what is the mechanism of action of sulfonylureas? So they will block the ATP sensitive potassium channels in pancreatic beta cells. So this we have seen during the release of insulin, that how insulin releases, right? So see this, sulfonylurea group can bind these potassium channels which are ATP sensitive. So by blocking this, sulfonylurea receptor is a component of these potassium channels. So by blocking this, depolarization will start, so that there is an increase in calcium level and exocytosis of insulin will take place, right? Now coming to adverse effects of sulfonylurea, the major problem is hypoglycemia. Hypoglycemia is lowest with tolbutamide, among sulfonylurea, because tolbutamide is having low potency and short duration of action. The second problem of sulfonylureas is weight gain. Another problem is disulfiram-like reaction with alcohol. So it should be avoided in alcoholic patients, or while prescribing sulfonylurea, we have to write advice that avoid alcohol during the therapy with sulfonylurea. They should be cautiously used in kidney failure patients, liver failure patients, and they are contraindicated during pregnancy because they are teratogenic in nature. So remember, these are the adverse effects of sulfonylureas. And what is the main adverse effect? Hypoglycemia. Next group is meglitinides. Examples are repaglinide, nataglinide, etc. So the name will end with glinide. Okay. Meglitinides are fast-acting, short-duration, non-sulfonylurea. These are specifically designed to minimize the mealtime blood glucose peaks. What is the meaning of that? So when a patient of diabetes mellitus takes meal, then the glucose level will be at peak after meal. So to control this peak of glucose, meglitinides can be given just before the meal. So this is given before each major meal to control postprandial hyperglycemia peak. Okay, so this group of drugs is specifically designed for this purpose. Hypoglycemia can occur with meglitinides, but less as compared to the sulfonylurea group. So remember, meglitinides, where they are used in diabetes mellitus, to control postprandial hyperglycemia. Okay, coming to next group, that is DPP-4 inhibitors. What are the examples? Sitagliptin, vildagliptin, all the gliptins, linagliptin, sexagliptin, etc. So the name will end with gliptin. Now, what is the role of this DPP-4 that we will know? Before that, understand this. Upon ingestion of meals containing carbohydrates and fat, first of all, GLP-1 is secreted from L cells in intestine. GLP-1, that is glucagon-like peptide 1. Okay. So this secretion of GLP-1 sets off a collection of actions like stimulation of glucose-dependent insulin secretion. This is the most important action of GLP-1. Then it suppresses glucagon secretion. It slows the gastric emptying. It suppresses appetite. And in long run, it increases the beta cell mass and maintains their efficiency. So all of these are the actions of GLP-1, that is glucagon-like peptide 1. So that we can say that GLP-1 is a friend of insulin. So it will help insulin to secrete, it will help insulin to lower down the blood glucose level in as many manners as GLP-1 can do. So this GLP-1 is metabolized by one enzyme that is nothing but the DPP-4. So GLP-1, if it is active, DPP-4 can cause inactivation of GLP-1. So if we give inhibitor of this enzyme DPP-4, we can increase the activity of GLP-1. So these drugs, sitagliptin, vildagliptin, etc., they are orally effective DPP-4 inhibitors. With this group, there is lower risk of hypoglycemia. Decrease in glycated hemoglobin is equivalent to metformin. We'll come to metformin. Adverse effects of this group is nasopharyngitis and pancreatitis. Remember, dose adjustment should be done in renal failure with all of the DPP-4 inhibitors except linagliptin. So this is your MCQ question. Dose adjustment in renal failure is required with all of the DPP-4 inhibitors except answer is linagliptin. Now we are coming to biguanides. That is a group of metformin. So these biguanides are derivatives of anti-malarial agent chloroguanide. First, fenformin was there in the market, which was banned because of lactic acidosis. Then came metformin. Metformin, what is the mechanism of action? It acts by activating adenosine monophosphate dependent protein kinase, that is AMPK. So by activating AMPK, metformin decreases hepatic glucose production, increases the use of glucose by skeletal muscle and fat cells, and decreases intestinal absorption of glucose. So all of these actions are of metformin. What is the mechanism? It activates AMPK. What is AMPK? Adenosine monophosphate dependent protein kinase. Now, metformin is considered as a drug of choice for all type 2 diabetes mellitus patients, means new cases. So why this is so? So these are the reasons behind it. First, it is highly efficacious if given alone. So when the new case of T2DM comes, if we want to prescribe single drug, of course we will start with single drug. So if we give metformin alone, it will control the blood glucose level in majority of cases alone. Second, it does not cause hypoglycemia. Hypoglycemia is not a problem with metformin. So it is considered as a euglycemic drug. Third, it causes weight loss. So it is beneficial in obese patients. Fourth, it improves lipid profile. And maximum reduction in glycated hemoglobin amongst oral antidiabetic drugs is with metformin. So now you can correlate. Fifth reason, it has potential to prevent complications of diabetes. And remember, it is the only oral antidiabetic drug to decrease the macrovascular events. Only oral antidiabetic drug to decrease macrovascular events. And sixth and last reason is it can be combined with any other antidiabetic drug. It has no problem with any other group of drugs. So it can be combined with any other anti-diabetic drugs. So because of these 6 reasons, metformin is considered as drug of choice in new case of type 2 diabetes mellitus. But what is adverse effect of biguanides? So these are minor side effects like gastrointestinal upset, GI upset, nausea, anorexia, vomiting. Then metallic test. Rarely it can cause lactic acidosis like his elder brother fenformin, but this is rare. It can cause vitamin B12 deficiency in long run because the absorption will be disturbed. It is contraindicated in hepatic and renal impairment as well as in alcoholic patients because in such patients there is more chance of developing lactic acidosis adverse reaction. So it should not be given in such patients. What are the other potential uses of metformin other than diabetes? So these are infertility with PCOD. PCOD means polycystic ovarian disease. So metformin can improve the ovulation if given in such patients. Another potential use is obesity because we have seen that metformin promotes weight loss. So it can be used in obesity, but these are the other potential uses of metformin. So now coming to glitazones. Glitazones are also known as thiazolidinediones. Pioglitazone is used. The earlier rosiglitazone was banned because of heart failure. These drugs are considered as insulin sensitizers because they will stimulate PPAR gamma receptors, that is peroxisome proliferator activated receptor gamma on which are present on muscle, fat, and liver cells. So they will decrease the insulin resistance. Remember, this group of drugs can also act on PPAR alpha so that they can increase HDL cholesterol and can decrease the triglyceride levels. So this is the additional action of glitazones. Adverse effects of glitazones is edema, weight gain, and other adverse effects like headache, myalgia, and anemia. They should be cautiously used in heart failure patients, in liver disease patients, in elderly women, because they can increase the chances of fracture. Then the next group is alpha glucosidase inhibitors. The examples are acarbose, miglytol, etc. Remember, alpha glucosidase inhibitors, they will inhibit this enzyme alpha glucosidase. This enzyme is present in GIT. And what is the role of this enzyme? To facilitate the absorption of sugars, complex sugars. So by inhibiting this enzyme, acarbose and other drugs will delay the absorption of complex sugars. So they are taken at beginning of each meal. So this group of drugs can decrease blood glucose in both type 1 as well as type 2 diabetes mellitus, but not approved by FDA. Okay, it is not approved by FDA. Though they can decrease blood sugar level in both type of diabetes mellitus cases. These are contraindicated in cirrhosis, malabsorption, and severe renal impairment. The adverse effect, the common side effect is bloating and diarrhea. One important thing in this group is if hypoglycemia occurs by concomitant using of other drugs. So what advice we will give to patient? If patient is on oral drugs or insulin, the chances of hypoglycemia are there. So what advice we will give to our patient to prevent such hypoglycemia? You can write your answer in comments. 30 seconds will be given. Which advice we will give to our patient while prescribing a drug which has potential to cause hypoglycemia? Quick, you can write down your answer. What we can do, which measure we can take, think logically. Which measure we can give, we can take, which advice we can give to patient to prevent hypoglycemia while on a drug which has potential to cause hypoglycemia. So the answer is we can give advice to keep a thing that is either biscuit or chocolate like that. So if a person feels that he or she is under hypoglycemia, we have seen the symptoms of sympathetic system, then immediately if a person takes this biscuit or chocolate, then the glucose level will not further fall down, so that hypoglycemic coma we can prevent. But if a patient is under alpha glucosidase inhibitors, this reversal will not occur with chocolates or biscuits, meaning thereby complex sugars. So the simple glucose is must for reversal of hypoglycemia because of alpha glucosidase inhibitors. The next group is SGLT2 inhibitor, sodium glucose transporter 2 inhibitor. The examples are dapagliflozin and canagliflozin. Their mechanism of action is they will inhibit the sodium glucose co-transporter 2 in proximal tubules, so that there will be no absorption of sodium as well as glucose, and both of them will be excreted in urine. So this is the mechanism of action of SGLT2 inhibitors. The name will end with gliflozin. There is no hypoglycemia, but weight loss may occur. Other adverse effects are glycosuria, because more and more glucose will be excreted. Increased risk of urogenital infection will be there. They are contraindicated in renal insufficiency. If kidney is not working, we cannot give SGLT2 inhibitors. Now the last group is dopamine D2 agonist. Example is bromocriptine. It is approved as adjuvant in type 2 diabetes mellitus patients. What is the mechanism? If given early morning within 2 hours of awakening, it can decrease the insulin resistance by acting on hypothalamus, because the circadian neuroendocrine rhythm, it is reset by dopamine. Okay, so this is similar to migratory birds like flamingo. So during the stage of hibernation, which is called as shit nidra, the dopamine level is reduced and circadian neuroendocrine rhythm is not reset, leading to insulin resistance. So this similar thing occurs in type 2 diabetes mellitus patients. So these are the other parenteral drugs other than insulin, which is pramlintide, amylin analog. So we have covered oral drugs, we have covered insulin. Now, these are the example of other parenteral drugs which are used other than insulin in diabetes mellitus. So remember, pramlintide, it is approved in type 1 as well as type 2 diabetes mellitus cases. Then GLP-1 analog. The examples are exenatide, liraglutide. This is GLP-1 analog, okay? But these are used parenterally, amongst which liraglutide is also approved in obesity. Teduglutide is a GLP-2 analog which is approved for treatment of short bowel syndrome. So these can be your MCQ questions. Remember this. Pramlintide is amylin analog which is approved in both type 1 as well as type 2 diabetes mellitus. GLP-1 analog like exenatide which is used in diabetes mellitus cases, but it is given parenterally, not orally. So we will summarize today's topic. Only regular insulin can be given intravenously in case of emergency. Insulin degludec is a new ultra long acting insulin which can act up to 40 hours. Beta blockers can mask all the warning signs of hypoglycemia except sweating. Metformin is considered as drug of choice for type 2 diabetes mellitus cases. Hypoglycemia, if with alpha glucosidase inhibitor, it is only reversed by simple glucose, not by complex carbohydrates. And apart from insulin, the only drug which is approved for treatment of both type 1 as well as type 2 diabetes mellitus is pramlintide. Okay, so with this, we complete today's discussion. Now we will follow 5 MCQs and it will be followed by question of the day. So this is your MCQ number 1. You can write down your answer. 30 seconds is your time. Your time starts now. Okay, MCQ number 1, all are preferred sites of insulin administration except. Yes, very good. Shivam, you are very correct. Bashukant, you are also correct. Anmol Punia, correct. Sanjana Pandey, correct. So insulin, all are the preferred site of insulin administration, like thigh, buttock, dorsum of arm, but insulin is not given around umbilicus. So answer is D. So any part of the body covered by loose skin can be used for insulin administration, such as abdomen, except 2 inches apart from 2 inches around umbilicus. Then we can give in thighs, dorsum of upper arm, flanks, buttocks, etc. Question number 2. Insulin causes all of the following except glycogenesis, hypokalemia, ketogenesis, and lipogenesis. Insulin can cause all of the following except. इंसुलिन क्या नहीं करता? ग्लाइकोजिनेसिस, हाइपोकैलेमिया, कीटोजिनेसिस और लाइपोजिनेसिस. Okay, some students has written answer is B. Think, is it B? Some has written D. Lipogenesis. Can insulin cause lipogenesis or not? Okay, answer A is also there. So I think this is difficult question for you. Some has written A, some has B, some has D. Hypokalemia, D, B, B. Okay. Here the answer is C, that is ketogenesis. Insulin can cause glycogenesis. Glycogen to banega because insulin want that glucose should decrease, so glycogen can increase. Insulin can shift potassium ions inside, so hypokalemia can occur with insulin. Insulin can cause lipogenesis because insulin wants to utilize glucose. But ketogenesis is not occurring with insulin. Insulin inhibits the formation of ketone bodies. Therefore, deficiency of insulin can result in diabetic ketoacidosis. And that is why in diabetic ketoacidosis, we give regular insulin as a treatment intravenously, right? So the answer is C, ketogenesis. Next MCQ question. All of the following preparations of insulin are rapid or short acting, except you have to find out which is not rapid or short, except Lispro, Aspart, Glargine, or regular. Which of the following insulin preparations not rapid or short? Quick. Is it Lispro? Is it Aspart? Is it Glargine, or is it regular insulin? Some is written D, some is written C. Yes, Bashukant, you are right. No, it is not regular, not. Okay, so we'll come to the answer. Okay, you are writing regular. That is not an answer. Answer is C, Glargine. Regular is short acting. Lispro and Aspart are rapid acting. But Glargine is long acting, right? MCQ number 4, this is the image based question. You have to identify the drug X from this image. The drug X shown in the figure is likely to be, your options are vildagliptin, exenatide, pramlintide, or dapagliflozin. Which is the drug you have to identify? Quick, quick. What is your answer? There is no negative mark. You can write down any option. This is learning only. Okay, someone has written B here. Just see in the figure what is the mechanism given. Yes, anyone want to answer? Exenatide, D, C. Senior is correct. Who is senior? No, A is not the answer. So C is not the answer. I will come to the answer. Senior is correct. Answer is D, gliflozin. It is SGLT2 inhibitor. So SGLT2 inhibitor and with the name end with gliflozin. Dapagliflozin, canagliflozin, like that. Fine. So now the last MCQ question, then it will be followed by question of the day. So last MCQ question, MCQ number 5. Again, image-based question. You have to identify the drug X shown in figure. Options are same: vildagliptin, exenatide, pramlintide, or dapagliflozin. So now you know that dapagliflozin is not an answer. Hint mil gaya. So you have now only 3 options: A, B, or C. Yes, I have given you hint. So now it should be easy. Bashukant has written C. Pooja Patel D. Anmol D. Think. Drug X inhibiting some enzyme there. Yes, senior has written A. Senior has written A. Anmol A. Correct. The answer is vildagliptin. This was DPP-4 inhibitor. So the name will end with gliptin, vildagliptin, sitagliptin, linagliptin, etc. So now the time to question of the day. Before that, you can download this app. Again, I would like to specially thanks to Dr. Sunil sir for providing this platform. And all of you can subscribe to Nextillo channel and you can download the app and you can use the coupon that is helping hand to avail the app for 3 months at just 89 rupees. Yes. So now the time of question of the day. Be ready. So the winner will be selected by Nextillo team. Question of the day. In a patient with type 2 diabetes, which drug mimics the action of incretins to augment glucose-dependent insulin secretion? Options are glycoside, exenatide, repaglinide, or pioglitazone. In a patient with type 2 diabetes, which drug mimics the action of incretins to augment glucose-dependent insulin secretion? Glycoside, exenatide, repaglinide, or pioglitazone? Yes, folks, give your answer. Remember, type 2 diabetes case, action of incretin. If you remember physiology, you will know the answer. If you connect the today's knowledge with your physiology knowledge, then you can give answer. Okay. Answers are there. Quick. First of all, you should know incretin. Then you should remember the mechanism of action. Is it glycoside? Is it exenatide, repaglinide, or pioglitazone? Now I think all the answers are there. Okay, someone is writing answer still now. Last 30 seconds to give answer. Okay, time up. Here the answer will be exenatide. Exenatide is a glucagon-like peptide, GLP-1. GLP-1 is an incretin which is released from the small intestine that enhance the glucose-dependent insulin secretion. So if you know that incretin is GLP-1, then you should know that GLP-1 analog, which is exenatide, liraglutide, and these are not used orally. These are used parenterally, right? So all other options were of oral anti-diabetic drug, but exenatide is given parenterally, which is a GLP-1 analog, and GLP-1 is an incretin. Okay. So the winner, as announced by Nextillo team, for question of the day is Dr. Bashukant. Okay. Please send your photo and contact details on support@nextillo.com. So with this, we will conclude the today's topic. Thank you.